Thanks, Vivian. Hello, everyone, and welcome. I am Michelle Kearney. I'm a doctoral prepared nurse practitioner, and I'm the clinical training lead here at Viz AI. So I'm responsible for the development and delivery of our clinical education and training. So before that, I have for 20 plus years, I was a nurse and a nurse practitioner. And most recently, in the last 12 years, I've been a cerebral vascular nurse practitioner primarily. So I have a lot of stroke and neurology expertise in the interventional space. So welcome, and I really appreciate you joining. So we'll get started. So what we're going to talk about today is hemorrhagic stroke, what it is, why it's a big deal, and what we can do about it. So first, what is a stroke? Basic stroke. So there are two major types. Of course, it's a sudden impairment of brain function because the blood flow to a portion or portions of your brain is stopped. And that can either happen because there's a blockage in a vessel, perhaps because of a clot from elsewhere. Oh, goodness. Okay. From elsewhere, like the heart and atrial fibrillation, or maybe a plaque is built up and it's gotten really tight in that vessel, and that plaque becomes irritated and a thrombus forms because of inflammation. Or there's a hemorrhagic stroke and such that maybe an aneurysm or an arterial venous malformation ruptures in that subarachnoid space, causing a subarachnoid hemorrhage. Or what we're going to talk about today, this hemorrhagic stroke, where these vessels become friable over time and kind of tear inside the parenchyma. So we often call this intracerebral hemorrhage, but it's also intraparenchymal hemorrhage. So you often hear ICH or IPH interchangeably. Either way, you still have the facial droop, the weakness on one side of the body or the other, slurred speech, confusion, changes into balance, dizziness, vision or eye movement changes. And then the last two, this headache and loss of consciousness, are often associated with hemorrhagic strokes. So there are different types of intracranial hemorrhage, and I think that it can be a little confusing. So it's not always a stroke, right? I get this call a lot in the hospital. Hey, we have a head bleed. Is this really a stroke? Do I still have to do my NIH? That sort of thing. So when we're talking about intracranial hemorrhage, there are a lot. There are a few of them. So we have the epidural in your upper left corner. And what we need to know about these is really where they are, right? So they're all intracranial because they're inside the skull, but they're not all intracerebral. So this epidural hematoma is just above the dural layer and beneath the skull, and it's an arterial bleed. And so you know that this is that very typical presentation where there's probably some sort of injury, the person loses consciousness, they wake back up, and then they lose consciousness for a much longer time. And these are emergent surgeries often associated with trauma. And then you have the subdural hematoma, which is venous bleeding, and that's just under the dural layer, and it can wrap around the skull here. And that is also not a stroke. But then you have the subarachnoid hemorrhage, which is arterial blood in the subarachnoid space. As we talked about just a second ago, maybe an aneurysm ruptures. Something's happened in that circle of Willis causing a subarachnoid hemorrhage. And then, of course, here, that intracerebral hemorrhage, where the ruptured vessel inside that tissue, or hemorrhagic stroke, intraparenchymal hemorrhage. So, these bottom two are considered hemorrhagic strokes. The way we differentiate them is always a non-contrast head CT, because there are three things that are white on a CT scan. It's blood, bone, and contrast. And if it's non-contrasted, what you're seeing then is bone. Also, when you're reading imaging, just think about, this is what we call the coronal view, and that is, think about it as putting a crown on someone's head. And so they're looking back at you. In all imaging, this is the right side and this is the left side. You can see this epidural bleed on non-contrast CT is kind of this biconvex or lens shaped. And that's because it's a really tight space here, and it's arterial, and it just starts to push in on the parenchyma. This subdural hemorrhage, you can see here again, this is going to be an axial view. So you're kind of looking down from the top of someone's head, or maybe up from their feet in slices. Again, this is still the right side and left. You can see that there's blood going along. So as we age, this space gets a little bit bigger, and there is a little bit more potential space there for that hemorrhage to just wrap around in this crescent shaped. And here you can see in the subarachnoid hemorrhage, you have a really nice, again, coronal right, left side, and you can see that circle of Willis highlighted there for that subarachnoid hemorrhage. And then finally, again, coronal. This is right and left, and this is going to be a thalamic kind of basal ganglia bleed, but you can see these hemorrhages pretty bright. Globally, how big of a problem is this? So out of the 12.2 million strokes per year, 28% of those are actually intraparenchymal or intracerebral hemorrhages. That's 3.4 million. And this is actually the most deadly form of stroke. I know that we've always been taught that, hey, the subarachnoid hemorrhage is the most deadly because we know that, for every two people that have one's not going to probably make it to you because they're so devastating at the beginning. But these have a really early term mortality rate. So they might come to you, but then their mortality rate at 30 days is really high. 6.5 million people die from stroke every year, and then 3 million of those are due to an intracerebral hemorrhage. In the United States, when you look at this map, the teal colors are the higher numbers, and there's still 80 to 120,000 a year. This is 2017 data. The mortality rate, again, 30 to 40% in that first 30 days. The ICH costs were 12.7 billion, and that incidence of ICH is going to continue to grow as we age, and then anticoagulant use is a real contributor. The other thing here, you can see there's the stroke belt. So I live here in Nashville, Tennessee. You can see we're in that dark teal color, which means higher stroke death rates. And the incidence is higher here in the stroke belt. And it's also 1.5, a little bit higher than 1.5 incident rates for Black and Latino groups. And of course, in the lower and middle income groups, it's higher death rates than those high income groups. And that's really about access to care. So we have some disparity here in ICH, just like in ischemic stroke. So why is it so deadly? Why am I saying that this has the highest mortality rate? Well, first, what we have to respond to is going to be this primary injury in intracerebral hemorrhage. So that's going to be this part, right? You have the hemorrhage, it happens, there's an acute mass effect that happens. So you've got to make room, right, for this hemorrhage. It's coming on suddenly. If you have a tumor, there'll be some compensation over time, but you just think about this is a tumor that happens in, just a few seconds. And so first you get this abrupt increase in the ICP, reduction in the blood flow going to the brain because now there's there's more pressure against that blood flow going in, and that can lead to herniation. So then you also worry that this hematoma starts to bleed over into the ventricles, and you're having that midline shift too. So as that hematoma is taking up space, it's pushing the tissue over. So you're having midline shift, you're having IVH, and again, herniation. So that means we really need to do some surgical evaluation. So that's our primary injury. This would be a normal brain. The thing that really causes that 30-day mortality is this secondary injury. So a lot of times, many of these ICHs within the first 24 hours will grow. So they keep growing and they expand. That's why it's so important for us to keep the blood pressure under control, to reverse our anticoagulants and say, hey, this is a stroke and we need to act really quickly. And then also in that secondary injury, you can see that this hematoma will start to dissolve over time. That breakdown of the hematoma causes lysis, it's iron toxicity, the hemoglobin has some toxicity to it. You start to get neuronal necrosis, free radical formation, lots of inflammation, and all of that can disrupt the blood-brain barrier. So all of these are that secondary injury and can cause the higher rates. But we're going to really focus today on this primary injury, but just know that the secondary injury is a really big part of what happens to your patients. So this is overly simplistic, right? So this is our current workflow for an ICH. It doesn't differ a ton from ischemic stroke at the first, right? You've got it. You hope that somebody calls 911, but they have an incident. They call the 911. EMS brings them to the hospital. Once they're evaluated for some sort of neuro event, and then you probably get a non-contrast head CT. Sometimes places do the non-contrast head CT, the CTA, and the CTP all at once, depending. But you do this non-contrast head CT, and now the radiologist has to read it, right? So what we need to do, just like our metrics for ischemic stroke, we have door to MD, we have door to scan time, and we have door to read time. But here's where it changes. So now the ED um, provider receives the result that, hey, there's a bleed. And now we need to get a specialist to them, and that specialist needs to do an ICH score. And then we have door to decision time. Are they going to surgery? What are we going to do? What about the disposition? Are we admitting them? Are we transferring them? What are we deciding to do? And then if there is going to be an intervention, what that door to intervention time is and what the door in and door out times. It has become a big priority in 2023, and I think it'll continue that that ICH is a really big deal. There was actually a memorandum put out earlier in the middle of 2023 too, that says, hey, we're not really moving very fast on these ICHs. So you are going to see the Get With the Guideline stroke. They're really going to start to address these issues, right? So you're going to see more of that, and ISC's coming up, so you're going to see some extra stuff coming out of there. We need to do that baseline severity score. We're going to need to reverse the anticoagulants. We don't really need to do a lot of platelet transfusions. So if they are being done, they'll want to talk about that. And, you need to do the dysphagia screen. So all the things I know that everybody's already doing are going to become even more priority for Get With the Guidelines. But what kind of interventions can we do anyway? So there are open surgeries. We've been doing those for a while for ICH. So we can, open the skull, do an irrigation of that, and take out that hematoma, put the skull back on. Or we have this minimally invasive surgery or endoscopy. So that is relatively new. Folks have been doing it for a while, where you just use a much smaller insertion area. You go into the hematoma, usually with some sort of endoscopy or other tool, and then just kind of irrigate that clot out very specifically. And so there's a lot of data showing that this is helpful. It's just as helpful as craniectomy, and maybe even so. There's some trials that are going to be closing soon, and there'll be some new results coming out. And then, of course, we have that external and ventricular drainage. We'll talk about those, but not everybody can do those. So how do we make sure that those patients get to the right place? So there's a pyramid of certification in stroke centers in the United States. We have the basic hospital there at the bottom, where we assess and identify and stabilize and transfer the patients. Next would be that acute stroke ready hospital, where we have the IV thrombolytics. They have CT scanners. They have stroke expertise, usually from telemedicine. So this is not going to help you too much if you do the CT scan and see a hemorrhage, right? They can do IV thrombolytics, but we've got to do something next. And so where those hemorrhages typically go are going to be this comprehensive stroke center, where they have all these functions below, which are stroke units, coordinators, stroke services, thrombectomy capabilities, but they don't always have that full 24/7 neurosurgery care. And so you're going to need that for a comprehensive stroke center. There's a lot of talk on what the primary stroke centers maybe could handle. So if it's a really small stroke, maybe hemorrhage, maybe they could go there. But for right now, the goal would be to go to one of these comprehensive stroke centers. And when you're looking at that, you can see that there are many fewer comprehensive stroke centers than primary stroke centers or acute stroke ready hospitals. So the comprehensive stroke centers are often overwhelmed. So which of these, we'll start our interactions now, which of these is considered the deadliest type of stroke? So, this is a little tricky, right? Because if you've been in nursing a long time, you know that subarachnoid hemorrhage has to be the worst. It has to be the most deadly. But truly, the intracerebral hemorrhages are the most deadly form of stroke because they have the highest 30-day mortality rate. And, if you think about that, if only half of your subarachnoid hemorrhages make it to you, then you're not going to have that long-term mortality rate. And most of the time, subarachnoid hemorrhages, if they can be treated and they get to you, actually do okay. But these intracerebral, intraparenchymal hemorrhage patients just don't. So which of these is the primary injury in intracerebral hemorrhage? And you can check all that you believe. Yeah, everybody got this right. So yeah, it's that first hemorrhage, right? That hematoma, which I kind of think of as a tumor in 5 seconds. That acute mass effect that it causes, that will start to push on the brain tissue there, and then the intracranial pressure because of that is going to go up. So to that point, let's go ahead and go over that anatomy and what happens. So when we're talking about ICH or IPH and brain anatomy, there are really three big pieces of that. So we have the skull, of course, is that box that it's fixed, right? It's not really compliant, not compressible, and it holds the following. It holds the parenchyma, which is that brain tissue. It holds the ventricles, which produce, circulate, reabsorb CSF. That really cushions the brain. And then we have the blood supply that we don't always think about, but really happens, right? We have to get blood into the brain, and that means that it goes in through the arteries and out through the veins. So there has to be room for the blood, the ventricles, and the parenchyma in that skull. And so you can imagine if you add a hemorrhage to that, we have to start thinking about what would happen. So none of these are really compressible, but they can be displaced to try to compensate. So let's take on the anatomy first. So what we have, of course, is that frontal lobe, which is our filter, our smell, our judgment, our foresight here. And then you move backwards to the cortexes, the motor and the sensory cortex. You have parietal lobe, which is our attention, awareness, spatial orientation. Then that big temporal lobe here houses the language, the endocrine, the speech, and etc. And then a lot of our intellect. But you can't really talk about intracerebral hemorrhage or intraparenchymal hemorrhage without talking about some of those deeper tissues and deeper lobes, and we'll talk about that. But that's that basal ganglia deep inside, the thalamus that's deep inside. Also, the basal ganglia is going to be, our motor movement, our skill learning, cognition, and our emotional behavior. And if you think about the thalamus as really the kind of air traffic control of your brain, it's where those signals start to cross, right? And it's delivering the signals from your body to your brain. And if you mess that up, obviously you're going to have a lot of different problems. And then we have also places that we have hemorrhagic strokes are that cerebellar strokes and the pons, which is our whole autonomic functions, our hemostasis. The other thing about hemorrhage, you'll often hear us say it's either supratentorial or infratentorial. It's going to be really important, and I'll go over it in just a second. But we need to know if it's, basically there's a little bit more room here, right, for a hemorrhage. Not a lot, but more room than down here. So we're really worried about whether or not where it is in the brain in relation to the tentorium. So again, I said that we don't really talk about the blood supply. If you think about cardiac education, we know that there is an LAD and circumflex. We know all the vessels. We know all about the vessels in the heart, but there are vessels, of course, in the brain. And so looking at that, we have this anterior cerebral artery that goes up. So we have our internal carotid. It goes up, it goes into our middle cerebral artery, into our anterior cerebral artery, and back into our posterior cerebral artery. And each of those arteries is important, right? It feeds different parts of our brains. And then you also have this vertebral artery that goes up. It will join into the basilar artery, and off of that, you'll get these cerebellar arteries. And of course, that feeds your pons and your brainstem. So if you think of an area, when you think of about a hematoma or something attacking here, it's going to cause the blood flow not to get up into the brain. And then, of course, there are drainage systems here too that can't drain back out. So when you're looking a little bit closely at that MCA is a really large territory. And I think what's important also that I want to show you here is when you're going up to that MCA territory, remember the basal ganglia that was deep inside the brain from that sagittal view that we showed earlier. So you can see that they're little tiny vessels, and they're called lenticular striate vessels, and they're fragile, right? So if you know that you've got some hypertension, diabetes, et cetera, these vessels get really torn up easily. And so they are often places that will hemorrhage. So you've got that basal ganglia, you've got the thalamus, and again, that cerebellum and the pons. So these are all really common areas for blood supply. So this would be your ACA territory, that lobar. These patients are often 70 or older and caused by amyloid. Well, I'll show you some pictures of that. And then we also have, of course, that basal ganglion and thalamus, and then the PCA territory with the other two. So these are all common hemorrhagic sites. Then the ventricles. I like to think of these really as your irrigation and draining system, like if you were thinking about it analogously to your yard. So the choroid plexus here produces CSF continually, constantly, with an estimated of 400 to 500 cc's of CSF every day, produced and reabsorbed. So all of that CSF gets made and it circulates, and then it exits out that fourth ventricle. So you can imagine that if we had a hemorrhage here and the pons, it's going to start to squeeze off and enlarge across that fourth ventricle. And what will happen then is this can't drain out. So when I say that you have continually irrigation and drainage system, if you think about that, you're watering the yard, you have a ditch, it's working fine. And then suddenly the ditch is blocked off, and now your yard's really going to flood. And so that's the same thing that happens to the brain, and you get hydrocephalus here. And then you're going to need an EVD, so that external ventricular device, that drainage device, because you're no longer, that drainage system's not working. So you're going to have to divert that CSF. The other place is that thalamus. That thalamus sits right next to that left ventricle, to the lateral ventricles. And if that happens, then blood can actually go into that ventricle and start to cause some mass effect, and also fill up the ventricles with blood that can clot off the system, and also cause the need for an EVD to start draining that blood out. And these are the patients that often get those thrombolytics inside that EVD because it keeps clotting with blood. And to that point, if you have just spontaneously ventricular hemorrhage, then you would definitely need an EVD. But if you start to also have obstructive hydrocephalus because of either of those problems, you're going to need an EVD. We know that that is class 1 evidence. Whether or not you need the thrombolytic kind of depends on the situation, and they're still doing a lot of work, but it's either 2A or 2B evidence on whether or not that's helpful, right? But you can imagine if this was full of blood, you might need to do something to keep that catheter open. And then finally, we have this neurophysiology. Let's put it all together, right? We have that vault, we had the ventricles, we have the parenchyma, and we have the blood supply. So for the normally, all those things are actually going to keep your intracranial pressure at about 10, 5 to 15, right? An average of 10. And then your normal blood pressure is going to be, we'd like it to be 70 to 100 for your mean arterial pressure, which of course is the systolic minus 2 times the diastolic divided by 3. So for the purposes of this this activity, I'm just going to keep the blood pressure at the same rate. And we know that's not going to happen because of when the patient comes in with some sort of problem with the brain, their blood pressure goes up, right? We need to perfuse the brain. It's really important. It's priority number 1. And so when these patients come in, their blood pressures are often really high. But for the purposes of this, we're just going to keep it the same. So at this point, everything is good, right? If our cerebral perfusion pressure is our MAP minus our ICP, then it's 75. Great. We know that anything less than ischemia is bad. Because they're always telling us to keep our mean arterial pressure like 65 or so, because the brain needs a very specific amount of perfusion, at least 60, right? If, say, we add a hemorrhage to this, now our intracerebral pressure includes a hemorrhage plus the parenchyma, blood supply, and ventricles. Now let's say that RCP is 25. Now we know our cerebral perfusion pressure, because again, it's just our 85 here minus the 25 is only 60. If we don't control that blood pressure or do something about this hemorrhage emergently, and it continues to grow, then let's say it goes all increases to 30, right, our ICP, and now we've got a cerebral perfusion pressure of 55. And there's going to be a lot of displacement. So one example of intervening would be to add that EVD to reduce the pressure from at least displace that CSF to give us some time. If we don't do anything, then we have that Monroe-Kelly hypothesis, right? Again, our parenchyma plus the blood supply and our ventricles is really a constant amount. An increase in one, you might can decrease one a little bit in the other, but there's going to be a little bit of there's a cutoff, right? that hemorrhage gets so big and there's nothing you can do. And if you don't do anything, you can imagine that you're going to have herniation. So all of those hemorrhages can start to move that parenchyma. This is sort of really extended for traumatic injuries. But otherwise, if you had it here, you could get that lobar hemorrhage could cause this hernia this way. The thalamic and basal ganglia hemorrhages can cause that central herniation. Something out here, maybe a deep lobar in the posterior section could cause this herniation. Or you can get this awful tonsillar hernia because, again, you have that tentorium. Remember, this if you have a huge hemorrhage here, you don't have a lot of room, right? Or a lot of time. So you're going to get these tonsillar hemorrhages. So when I think about the tentorium and all the guidelines kind of are based on this, where do you have the most space? Where do you have the most time? So I think about supratentorial as Arizona, right? You can maybe find a home somewhere in Arizona, no problem. But if you think you can't in New York City, so that's infratentorial section I think of as New York City. So what about this? So someone has a basal ganglia hemorrhage. What vascular territory do you suspect was affected? This one's always a little tricky for folks because, the term basal ganglia really makes it sound like it should be in the basilar artery, but it is off of that MCA. So right behind your eyes in that deep area of your brain, that's where the basal ganglia are, the thalamus. They're coming off that middle cerebral artery in off of those lenticule So true or false, if there is a pontine hemorrhage, if there's a pontine hemorrhage, there's a higher risk of hydrocephalus. Yes or no? So if you remember, all that CSF is going to exit out of that fourth ventricle, which is really near the pons, really near the brainstem, because it's heading down towards the spine. And so if you have a hemorrhage there, it could definitely push over across that exit, that fourth ventricle, and cause hydro because now the CSF can't drain back out and it'll just continue to be produced. So good job. So what causes this? Like what would cause the ICH? So not all of these are strokes, so I'll just say that first. But first you have that cerebral amyloid angiopathy. So I mentioned that just quickly, but that's a lobar. They're often in this lobar area. You'll see them off here. Usually these patients are 70 years old. If we see this in a young person, we have to do a lot of investigation because that's not normal. They shouldn't have angiopathy. And if they do, then they might have that sort of that angiopathy everywhere else. So you've heard of carotid amyloid. So you're really worried about amyloid someplace else too. If they maybe they have chronic hypertension, and this is really the number one reason that this happens. So here is what I was talking about, the basal ganglia. So this is the MCA territory, all of this. There are those tiny vessels that come off and they start to rupture. Long-term blood pressure issues, hypertension, diabetes, high lipids, smoking, all of those things can cause these vessels to be really friable. And then we have trauma, which is obviously not going to be a stroke. We can also have cerebral vascular diseases and lesions like those arterial venous malformations, maybe deep inside that parenchyma where the capillary bed is. There's some sort of fistula that happens, and that could cause a problem. Moyamoya disease. Brain tumors have a lot of vascularization to them, and they can hemorrhage. Also, if somebody's had an ischemic stroke, that can have a conversion, right? If you've had a previous stroke, that increases your risk of having an ICH by 20 times. And if you have a cerebral venous thrombosis, maybe this is a young person who's on oral contraceptives, maybe also smokes, that puts them at high risk of having a venous clot that would then cause a backup into that arterial section, arterial drain input also, and that would cause a hemorrhage. You can also have coagulopathies from liver disease, hemophilia, anticoagulant and antiplatelet uses can be other causes for that. And then we've seen a big uptick here, at least in the street drug related ICHs, so cocaine, amphetamines, and also infection. So if someone does use IV drugs, they can maybe had a valve, or either way, you can get an infection in the brain, and those can convert to hemorrhages. So DG here is going to get us through the rest of our session today. So she's 61. She has a history of high blood pressure, social alcohol use, and absent seizures. She presented to the ED via EMS because she had right-sided weakness, expressive aphasia, and right facial droop. Her neighbor found her down in her condo complex about an hour before she arrived. So her symptom onset's really unknown, but her friends were talking to her on the phone about 4 hours prior to that, and she seemed to be normal. So physical exam, she's awake and alert. She has expressive aphasia, so she can't really get her words out. She does have a little mild receptive aphasia, but she's moving her left side to remove her oxygen and such. So she has right-sided arm and leg weakness and right facial droop. Her vital signs, she's hypertensive, as we would expect. Her heart rate is 90. Her sats are 94, and she's on 3 liters nasal cannula. So to that end, what facility do you think she should go to? This is one of my favorite questions because almost everybody is right, even though the answers aren't the same. So, one, absolutely, maybe it should be the closest, right? Um, I feel like every state, every city, every county has a different protocol for this. But often, if you're within 30 minutes of a comprehensive stroke center and it looks like you're having a large stroke like this, most of these guidelines are based on large vessel occlusion, right? So you're trying to get somebody to a thrombectomy center or a comprehensive center, somebody who might can remove a large vessel occlusion. So, these often look the same, these big hemorrhages. And so it could be a comprehensive stroke center. If it was outside of 30 minutes, the American Stroke Association says, hey, if the onset is within that 4.5 window, you should go the closest because they're worried about thrombolytics. And so all of everybody was right. So, but basically a comprehensive stroke center would be, of course, the best if we suspect that she was having a hemorrhagic stroke. And what are some possible causes of her stroke? Yeah, absolutely. All of these, right? She's got long-standing blood pressure. She has alcohol use, social, but still can be a cause of this. Her age, she's 61. So as we get older, sure enough. And then I didn't say she had a cerebrovascular malformation, but she does have these absent seizures from something. So if that is the case, that could definitely cause her to have some sort of event. And then what side of her brain has been affected, her right or left side? And I'm not sure if you can see the screen, but she's moving her left side and having right sided weakness. Seems like it's a gimme. Everybody's correct. Yes. So she's having all these symptoms on her right side. This is most likely happening in her brain on her left side of her brain. And so all of that being said, what are like when she gets here, what kind of assessments we do? So a lot of times you get to the hospital and you're like, is this a stroke or not? And we use a FAST assessment or a BFAST. And we chose BFAST because while face, arm, speech, and time. So the face is uneven, arms are weak, speech is slurred, having trouble getting your words out, and time to call 911 certainly makes sense. And it's been around a long time. It worked. But we found that we were missing these balance patients. So the cerebellar strokes we were missing. We were sending them, they were giving them treatment for vertigo and sending them on their ways, or maybe just vision loss in one eye. We're sending them to ophthalmologists. So we were missing these strokes. So B FAST is a good acronym. And then I would add that T could also mean terrible headache, right? These hemorrhagic strokes often have those. And the next thing I would like to do is a neurological assessment. And so a lot of folks are like, I'm not doing that on everybody, right? They're not, those aren't neuro patients. But the American Association of Neuroscience Nurses, we actually came up with this white paper to standardize a neurological assessment, because this comes a lot. I helped get comprehensive stroke certification at one of my last hospitals. And this was the big thing. You've got all these options to choose in your EHR, and we needed to do a standardized neuro assessment for everybody. That way it would be helpful. So first you want to know when the timing is. When did her symptoms start? Were they slow? Were they fast? I told you it was 4 hours ago, maybe. A level of consciousness, her alertness, awareness, orientation, what her Glasgow Coma Scale is. So we know she's awake and alert. What about her language and speech? Following commands, is her speech clear? Is it slurred? So she's not speaking, right? She's got some expressive aphasia. She's following some commands. She's mildly receptive aphasia. So not great. And then her cranial nerve exam. So if you're like me, you didn't memorize that acronym, but we're looking for her eyes. What are they following you around the room? Are they tracking? Does she seem to be able to see? Where's her face? Is she grimacing? Is it even? Is she gagging? Is she drooling? Maybe she's lost her ability to control her own secretions. And what about shrugging her shoulders? What are your findings there? So we know she has a face droop, her eyes are open, and she's awake, alert. And then we want to know if they're moving and if it's symmetrical. And if you can't get someone to tell you they can sense on that side, then you can add a stimulus. And then we want to know somebody's vital signs. So right now, this is the very basic standardized neurological assessment. And you can do that on everybody. I certainly advocate for it. So this is a baseline assessment. If you monitor her frequently, and we suggest in an intracerebral hemorrhage, intraparenchymal hemorrhage, that you do it every hour minimum, at least for those first 24 hours, because that hemorrhage can grow. And so that Glasgow Coma Scale is going to give us a lot of information about how she comes in. It also helps us with some of those scales that I was talking about are required when somebody comes in for an ICH. So minor brain injury, this is the one neuro scale. I feel like the higher you are, the better off you are. So, we want to know how she's doing. And so really she's got 4 points because her eyes are open. She's got 2 points because she's slurring her words and not completely following commands, etc. And then she has got full movement. And we're going to test her left side, right? The one that's moving. We're not going to test the one that doesn't. And so right now she's got a Glasgow Coma of 11. And so that fits into these stroke scales. Almost everybody, when they come in with a stroke, you're going to do that NIH because you're not sure yet maybe of what kind of stroke. And we know that we do this to figure out our outcomes. So the higher the stroke score on these folks, not so good, you have worse outcomes. And then, excuse me, and then you're going to do this ICH scoring. And actually these aren't fixed values, which I think is a really important part of that. So she came in with that Glasgow of 11, right? So she's going to get a point for this. Again, high scores here, not good. Her age is less than 80, so there's no points for that. We don't really know where this is, but from her symptoms, you kind of assume that it is not cerebellar, right? We think it's probably supratentorial, so no 0. We don't know how big it is, but we'll just say it's a 0, and we don't know about this. But right now, we're just going to say, hey, her ICH is a 1. So her chances of being dead at 30 days is 13%. Now, let's say that an hour goes by and her blood pressure is still really high and her Glasgow Coma Scale drops. And now it's going to be in the 3 to 4 range. She's going to get 2 points. And if we imaged her, we know that her volume is high. So that would take her from 1 to 4. And you can see that her chances of being dead now have gone from 13% to 97%. And so it doesn't take a lot to change the probability that someone will be dead at 30 days in an ICH. And then the final thing we use is that modified Rankin scale. So what we want to do when somebody comes in now, we've done that assessment, we've stabilized her, we want to do that non-contrast head CT because we want to know where the bleed is, what kind of is there midline shift? Are we having a mass effect? What about ventricular involvement? And then we need to get their blood pressure less than 140 in an hour with a maintenance of 130 to 150. And then we want to reverse the anticoagulation and then recommend hourly assessments. So let's go on to those images. So ICH has really progressive imaging for etiology. So you kind of figure out clinically what you think the problem is, but the first thing you want to do is that non-contrast head CT. Remember, we want to know if there's a bleed, where it is. It helps us know if it's supra or infratutorial. And then we want to see if there's a risk of hematoma expansion, or maybe a vascular cause. Maybe there's an aneurysm. So we might use a CTA or an MRA. And then a venography. So if these two don't help, we still don't know why someone has a hemorrhage. We might need to do a venography or a venogram. So this would be somebody who meets that other criteria, right? The young person on oral contraceptives, smoking, etc., maybe a postpartum person. So and then if we still don't know, we might do an MRI. Sometimes they do these after the CT a day or so again, and you do an MRI plus an MRA plus an MRV if you're really not sure. So you get all of them at once. And when you're looking at this, I just want you to notice all of those tiny little dark spaces. So these are old bleeds in the head. These are all in that lobar area. This is amyloid. This is what cerebral amyloid looks like. And if we still can't figure it out, we're going to need to do an angiography in the suite. So let's go through those. So first we use that CT. And why? Because it's fast, it's available. Usually it's lower cost. Almost everybody can do it, right? It helps us decide what kind of bleed type. Remember the very beginning of this, if it was subdural, it looked like this, it kind of wrapped around the skull here on the outside. An epidural came down like this. A subarachnoid would show us our circle of Willis, but this is going to be a big intraparenchymal hemorrhage. And then now when we're looking at it, it also can help us measure it. So that CT, they can actually do measurements on the CT scan to figure out how big it is. Remember how important the size was on treatments. And then we want to know, is it supratentorial or is it infratentorial? And you can see here that this is going to be supratentorial. This is a basal gang thalamic, mostly thalamic, but also some basal ganglia hemorrhage here. And it helps us kind of investigate for etiology. We're looking for that midline shift, right? And mass effect. And then we want to know if it continues to bleed. And sometimes you can see that on a CT scan, but we want to know what the plumbing looks like. So is there a spot sign, right? In a CTA that helps us know if there's bleeding. And then we also, if this person is coming with those lobar hemorrhages and they're less than 70 years old, we're going to need to do a CT scan, CTA, because maybe there's a big vascular cause of this. And so next, let's look at that. So CT scan shows us this, right? We can see this. Is it going to keep bleeding? Well, you're not completely sure, but it does look a little different. So sometimes you can tell that the bleeding layering looks a little different on a CT scan, but a CTA will tell you definitely. So this is showing up as contrast because the blood is following the contrast, and the contrast is following the blood, and it's continuing to bleed into that space. At 24 hours, if you do nothing, then this is what it will look like. You've got this big hemorrhage here. You've got a hemorrhage here in the ventricles. This is a much worse bleed. And so we're always looking for perhaps exaggeration or expansion of that hematoma. So what a CTA does is really it's iodine-based contrast. It's timed to specifically highlight the cerebral arteries. And so, like I said, the contrast will track into wherever the blood flow is going. So if it's going into that hemorrhage continuously, you're going to see it on a CTA scan. It's pretty fast, takes about 5 additional minutes. We use it all the time in ischemic stroke, like looking for those large vessel occlusions. You can also see it in 3D. And helps us know about collateral flow. And say that hemorrhage was really large and starting to cause problems and kind of pushing on some of the other blood vessels, you would see that here. And we do that venography next. Okay, we've done those other things. We still don't know why this person's had a hemorrhage. And now we're really looking at the anatomy and patency of the veins. It's looking at our venous sinuses with contrast. So possible findings would be a dural venous sinus thrombosis. So maybe there is a clot in that sinuses that's causing a backup and then a hemorrhage. Maybe there's a vascular malformation where the veins and the arteries are gathering together there and it becomes a high pressure system that is hemorrhaged. Um, it can substitute this with an MRV. So you could do an MRV instead. And sometimes people have idiopathic intracranial hypertension without a thrombus. So you maybe have a really tight area or stenosis in this that's causing that to back up and increase the pressure and then cause the bleed. But you're most likely to find one of those we most likely do those in those young people who are on oral contraceptives. And then why would we do an MRI for ICH? Well, there are really great things about an MRI. It can detect hyperacute ICH. So maybe you can see it early, you can see different changes really quickly. It could give us really a lot of prognostic information. And the expansion can be seen early on an MRI, and it shows areas of damaged neuronal tracts. So they use this a lot in surgery because when we're trying to decide about surgery, because you can do a really complicated MRI and it will tell you about those neuronal tracts, where the damage is and whether or not they might come back. And you might see one of those smaller IVHs, and it can detect a stroke mimic, right? If you didn't find a hemorrhage by chance. But we know that these non-contrast head CTs tell us if there's a bleed, which is what we need to know to get our protocol started. They're easier to monitor patients. There are really no contraindications. The staffing's easier to come by, and we're all a lot more comfortable as clinicians reading those. And then finally, when do you need to do a cerebral angiography? Well, suppose it's just a bleed in the ventricles. That doesn't seem very normal. So we need to look for a really tiny microvascular cause. And so you would need to take somebody into the endoscopy, the interventional radiology suite. Some people call them specials, but you access the radial or femoral arteries. You inject contrast under fluoroscopy, and you look at it from both the coronal views and that sagittal view to just get a really good 3D picture of this. And you're looking for some sort of maybe a smaller vascular cause of this. And so in these cases here, this is a patient who actually had, this is that lenticular striate coming off, and there's actually an AVM way up here. We wouldn't see it early. So this is after they've occluded it. And then this, of course, this is what we call an AVM, or arteriovenous malformation. You can see there's a tiny bit of area. Here's an aneurysm that really started rupturing and bleeding, and this would be the cerebellar arteries, and this would be superintentorial, and this is infratentorial. So we'd start to do that if we really can't figure out why this person had a hemorrhage. Okay, what do you think this is? What's the best description of this image? This one's also a little bit tricky, right? So a couple of people have put in acute middle cerebral artery territory infarct, and sure enough, this is some sort of like infarct, right, in that middle cerebral artery territory. It's in the MCA territory. But it's not a subdural hematoma because that would be blood on the outside here. An old MCA territory infarct would be black like this if it was chronic. So this is bright white on a non-contrast head CT. So this is going to be an ICH. You can see the spot sign in this because I said, there's some weird layering. It's all a little different area. So sure enough, that's a spot sign. All right, our guidelines for treatment are really based on how big that hemorrhage was, where it is, and their presentation. They did update the guidelines last year for the first time in a really long time. It had not been updated since 2013. What we know we need to do are these frequent neuro assessments every hour, right? Blood pressure control, reverse your coagulopathy, rapidly correct any intracranial hypertension, and then avoid all those medical complications that we try to avoid. What we did learn over the last few years was that you don't need prophylactic corticosteroids for hemorrhage. We don't do continuous hyperosmolar therapy. We can do intermittent. Platelet infusions really just aren't helpful. They can actually cause harm. Compression stockings alone won't keep DVTs away. You need SEDs. And then we don't treat seizures unless we see seizures. So all of these things are not evidence-based. And when we look at the workflow, remember we had that workflow where the patient comes in, the ED provider reviews them, they get the non-contrast head CT, the radiologist reviews it, and then you start to have these conversations. So what about whether or not they're a surgical candidate? Well, again, think about the territory. So these are things that we want to know. Is it supratentorial? If it is, then you should do an IVC evacuation, at least considered if that hematoma is at least 20 to 30 and or the Glasgow is moderate, or maybe there's a mass effect, edema, midline shift. All of those are good reasons to have a conversation about surgery. And patients considered salvageable, and it's a life-saving measure. So if you can't treat it medically, often also. So if you look at infratentorial, the big difference, you see this number. It doesn't have to be as big, right, to start to think about doing cerebellar decompression or surgery, right? Because again, there's not as much room. That's New York City. We don't have as much room down there. So you'll start to see you'll move a lot faster to try to evacuate those. The big part of this that we don't always talk about is family discussions, right? Surgery is not benign, and maybe this person wouldn't want surgery, right? Maybe they wouldn't want these things. It's really important. If you don't do surgery, let's talk about medical management. So if you don't do it, what we do is like we send them to ICU, you continue to do recurring imaging, you have to do that neuro assessment every hour to make sure there's no changes. You keep the blood pressure under control. If there are changes, you do another CT scan. Then you decide again, are they a surgical candidate? And you do this over and over. What are those surgeries? So we have the craniotomy. It's a large incision. You can see this large incision. These would be burr holes that you do often in subdural hematoma, but you open the flap, you do the dura, you open up the dura, you irrigate and evacuate that, and you put the bone flap back on. It requires OR and general anesthesia, right? And you disturb a lot of tissues. If you do maybe there's a lot of swelling and they decide to do a craniectomy, it's a similar procedure, but the bone flap just stays off. This minimally invasive surgery has had a lot of promise. And some people call it MIPS, which is minimally invasive parafascicular surgery. It's the same really guidelines. So they've been working on this, but supratentorial, again, they're not really talking about this for those infratentorial hemorrhages. If it's 20 to 30, just like the other type, if it's glioblastoma and you're being considered for hematoma evacuation instead of conventional, this is an idea. And with or without a thrombolytic. So sometimes they have to use thrombolytics because these catheters, as you're using them, will get clotted off. But the clinical trials really suggest that this improves the mortality over time, especially over medical management. The functional outcomes so far have been really neutral. But if you think about it, if you're just going in with this little catheter, so you make a much smaller hole, you open it up, use a catheter and endoscopy to go in, you evacuate this hemorrhage just through that small hole, and then you're not displacing all of this other tissue like you are when you're having to open up, move the brain tissue out in a big craniotomy. So these are the ideas. Here, I'm going to show you, this is something called a minimally invasive scuba procedure. They do this at Mount Sinai. This is their video. It's a little older, but they do it a little bit differently. But they're in the fluoroscopy suite. You can see they did an angio in the background. They use this tool. They go in, they guide it, and then with endoscopy, they go in and they aspirate all that hematoma. And while they're in there, if they see a lot of active bleeding, they can actually cauterize those. They also will do these under these functional MRIs that kind of map this out. And so often they'll have a much more detailed map with different devices to try to go in and just get that area of hematoma. And again, if you had to do a craniotomy for this, you'd have to open all of this up, move through the brain tissue, and extract it. So the current state of ICH workflow we went through earlier, right? We had the door to MD, the door to scan. We have all this communication, lots of phone trees that have to happen, right? These decisions. So a lot of times you wonder what AI can do for a workflow. And I'll say in advance that AI has made such a difference that they've recommended it for the last year in all stroke workflow. So I want to go through this quickly because I know for the sake of time, but there are consequences of ICH. So this is DG's um, real trajectory. So she did get, she was called to they were called to the complex. They bypassed that PSC. This is a big metropolitan center, but they took her to the CSC quickly. The CT showed a small basal ganglia hemorrhage. Her Glasgow coma was actually 12. And then she had to stay in the ED. Remember, I told you that comprehensive stroke centers can really be like really be stressed, right? There's no bed availability. So she ended up, there was no ICU. She stayed in the ED, a really busy ED. Her blood pressure on arrival was 180. It stayed that way even after an hour on medication. She was on Cardine. 2 hours, it still was elevated. Her Glasgow coma slipped to 9. So 6 hours later, she actually got even worse. So they did a CT scan and they saw that spot sign. So then she got intubated, flaccid on the right. She had global aphasia and then ended up with an AVD. So due to that spot sign, she wasn't really a good candidate for any intervention. She actually did get a minimally invasive procedure, but her outcome by 30 days was death. So the workflow challenges really are that you can have this slow recognition, right? We're really fast. You say, oh, they need TPA. You know you have to give TPA, so we're really fast. So that can be delayed in hemorrhage. Imaging results are needed urgently, and maybe it's you can't see them really quickly and you're waiting. And then the interventional and surgical needs require quick dissemination, right? You really need to know if somebody needs surgery. And then sometimes, like, I would write orders in the emergency department for the ICU, but because of our EHR, those orders for treatments, the carding, all the things, the reversal agents, if they shipped them off quickly to the unit, would not go through, and then the nurses couldn't get the meds. There's lots of issues, right? But if you use AI, and this is what AI does for the workflow, you still get this sort of thing, this door to MD, the door to scan time. Now what happens is that all of these people at one time can see the scan. So everybody can see it's a hemorrhage, right? So now you're not waiting for the ED provider to call the neuroconsultant. You're not waiting for the radiologist to call the ED provider. Everybody sees this at once and you get triggered. And then you can decide, I'm looking at this scan right now, are they a surgical candidate, right? Maybe you can you can also use the mobile device to say, hey, the family's here. They want everything done. Definitely a surgical candidate. And then you can contact that surgery team even on the app. So all of this really does increase the time, the treatment decisions, how fast we get things done, like how fast we can give our medications. So I really appreciate everybody's participation today. That was awesome. In summary, ICH is still the deadliest of all strokes, and we need early management because it's essential in preventing that expansion, right? So that got to treat that blood pressure. You got to reverse the coagulopathy. If you don't, it can really lead to worsened neurological injuries. We have to do that progressive etiology finding with imaging. That's what we do with that. And then workflow really benefits from from AI, right? And now it's actually recommended by the American Stroke Association for all stroke centers to use that so that you can improve that communication.